Thank you everyone for joining us tonight on today's meeting of advancing the role of GPs in holistic shared care of people living with severe mental illness. I would like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work, recognise their continuing connection to land, border and community, and pay respects to elders past, present and emerging. Also extend that respect to any Aboriginal colleagues who may be joining us today. So Abhishek, I'm one of the mental health program officers here at Sussman. You'll be seeing my face pop up from time to time just to make sure everything's working with today's webinar. So to start off with, I'll hand over to Dr. Andrew McDonald just to give us a brief overview of the session today.
Welcome everybody. So a very important topic that we're discussing tonight. For some, it will be a sort of introduction to holistic care. For many on the screen, no doubt it will be refreshing both to get some updated evidence and also a consumer perspective on what is a huge challenge for our health system. Across both our districts, Sydney Local Health District and South East Sydney Local Health District, we've been collaborating with the PHN for a number of years, trying to improve the physical health care and the integration of care between our districts and primary care. It remains a very steep challenge, and tonight we're going to hear, as I said, we'll hear Tim Lambert giving us an academic perspective. We've got Kizzy who will provide a consumer perspective. I think Mark's going to provide us with a case presentation leading to discussion, and then each of the districts will outline some of their priorities in shared care. And also Mark is going to speak to a trial we're about to launch, which is looking at trying to improve shared care using an online care planning website. So we've all been on this journey for a long time and really have only started to make initial progress in it. And there's a lot to do, and we recognise that from a LHD point of view, there's much that we don't do very well in terms of communicating with GPs and sharing information. But we really are focused. It is a key priority for our mental health service. And Tim, who you'll hear from shortly, was really the foundation of our Living Well, Living Longer program with his the CC Chip cardiometabolic clinic that he established. So look, you can see the agenda in front of you there. I won't keep you any longer. Unfortunately, I'm not able to hang around for the whole of the meeting. I'll have to go after about 20 minutes, unfortunately, but Andy Simpson is going to provide a summary of our shared care program in Sydney LHD. So thank you very much for joining. Be very happy to get any comments or suggestions via email or phone after the session. And with that, I'll hand back, and I think we're going to hear from Tim. So thank you, everybody.
Well, good evening, everyone. This is equivalent to the Python summarize Proust in 60 seconds. So excuse me if I push us along. We're going to quickly review. The first thing here is life expectancy. If you look at this, this is from ABS data from the time of roughly of federation until the last census that I have the data for. And as you can see, longevity increased for females a little more than males quite steadily over that period. I don't know how many of you in the audience are over 55, but you would not be living much longer if we were 100 years ago. So next, there's that the linear expansion of that. But if we look at those with severe mental illness, next, please. And next again, yep, what we're seeing is the longevity gap. Now, I've drawn that as sort of moving across. It's actually probably a downward slope. And that big difference, of course, is really the public health disgrace of premature mortality in people with severe mental illness. Taking away suicide, the major cause of this is, of course, cardiovascular illness. Next. So if we then look at the early warning signs, if you like, the danger signs going right back to the mid-90s in Scandinavia, even at that time, the cardiovascular mortality indexes were separating. So for the general population, they were starting to fall. And for those with schizophrenia, as one of the severe mental illnesses that we care for, it was already rising. And this is now, of course, 30 years ago almost. Next. But the early death in severe mental illness is often quoted at being 20 years when I see most pamphlets come out. And then when I look up literature, it's usually a reference to an editorial I did for the MJA, and I stole that from somebody else. Our data indicates that people are losing more than 20 years of life. And the data here from a whole bunch of, and if I look at them, a lot of those are fairly sort of right-leaning American states. Even if we go right back to between 97 and 2000, you can see the years of life lost was somewhere between 25 and 30 years. Next. So when we look at, there are two studies that have been done for mortality in people with severe mental illness. The first one and our one that we did a few years back coincided by saying, really, you're probably looking at an average age of death of 55, as opposed to say 79 to 83. And that's quite a considerable loss of life. But when I started all this sort of stuff about 1999, so what's that, 22 years ago, the gap was about 15 years, and it is now about 30. Those aren't very good statistics. Next. Okay, so very quickly, what should we be looking at if we wish to correct things? In the very brief time I've got here, I'm just going to start off with a summary point and say, please do not fall into the trap of thinking all of this is due to psychotropic medication. Yes, it plays a role, certainly in the early stages of the management of psychosis. But part of what we do, our long-term goals are to be able to model this in a rather sophisticated way. And I can tell you, after 3 years of treatment, medications drop out of any modeling we do about outcomes. Everything is already damaged. So let's not just concentrate on psychotropics. Yes, they are a modifiable risk factor, but let's look at the general risk factors very quickly. So these are all the things that we measure in every one of our clinics through our multidisciplinary team. So first, obesity is all roads lead to Rome or obesity or stem from it. You can see rates are somewhere between 1.5 and 2 times the Australian population. Insulin resistance is about 3 times the population or greater. And when we look at unhealthy lifestyle, it's likely to be somewhere between 3 and 5 times worse, particularly smoking, decreased physical activity and unhealthy eating, all of which we chart in a sort of micro fashion. Interestingly, though, some people forget this hypertension is also 2 to 3 times higher in the severe mental illness population. Hypoglycemia on over the whole lifespan is somewhere between 2 to 5 times greater in the population. But some of the work that hopefully will be in press this year, we've shown that in those that are between 25 and 40, the rates can be 20-fold elevated for diabetes over the general population. The cardiometabolic complications are not a problem of middle age for those with severe mental illness. They come about very early on. And it's a bit like movement disorders. There are often quite complex movement disorders in first episode. Kids who've never seen a drug, so it can't be just a drug-induced condition called tardive dyskinesia. The same with metabolic complications. Many are present before they've been treated. Dyslipidemia, the 2 to 5 is being generous. It's in big population studies, and our own data, it ranges between, again, about 10 times in the young and 5 times in the older patients compared to age and gender matched Australian population. We haven't got any figures on inflammatory, circulating inflammatory factors at this stage, other than we look at high sensitive CRP, but it is incredibly increased over the general population. And if there's one thing that explains everything, it's not whatever explains gravity, it's everything is caused by inflammation. Next slide. So if we look at the sociodemographics in our patients, we've got to always consider the age risk, because as I've already said, in our population, the younger have an incredibly high proportional rate compared to ABS data for everything. So we need to start screening from the onset of the first episode, and we start seeing people at 16 and don't finish until about 65, and we're about to increase that to 70. We've also got to remember race. Oh, I've been raced on. Just quickly, because we carry a huge proportion of our patients from high-risk ethnicities for diabetes and heart disease. So, for example, South Asia being the epicenter of early death from cardiovascular disease, we have very high proportion of ethnically at-risk people in the central Sydney area. Gender has to be considered because there are different risks for the different components. I'm sure you're aware of that. And the family history is at about 55% for people with severe mental illness, which of course is about 2.5 times or greater than the general population. But the one thing I just want to mention, the last two quickly, is we added about maybe 6 years ago, we added in sleep, particularly OSA studies. And we work very closely with our partners at the Woolcock. And it's very, very clear to us that a lot of the obesity and therefore the other problems comes through obstructive sleep apnea, which is undiagnosed. And of course, we do have a dental team, and periodontitis which leads to inflammatory cytokines in bulk, is a major risk factor for the premature cardiovascular disease. Next, please. So how would we deal with this? Well, if you're lucky, you have a multimodal clinical structure. So in any one afternoon in our clinics, you will see an endocrinologist, a cardiologist, a psychopharmacologist, stroke psychiatrist, and our psychiatrists are also medically trained, so they are many, they're interested in general medicine, and they of course cover all of that. And then we have a dietitian, an exercise physiologist, a dental screening team, and one of our sleep clinicians. So we obtain a full picture in one afternoon. Our job is to assess the risks in order to give advice. Next, please. But of course, we relate to the outside, and the outside obviously is with those that refer to us, which is a very small proportion of general practitioners, the health services themselves. And then our staff also work in the community, and the allied health staff, in terms of providing lifestyle changes. And out of that sort of relationship grew the concept of living longer, living well. So this is really a very integrated service that sees all the most severe patients. Or do we? Next. Next. So my last slide is to say, well, the reason there needs to be partnerships is that we would have thought after 20 years that our model of care, or even something remotely similar, would be all over Australia. And I'm very sad to say that the vision to care for the severely mentally ill seems to be not shared by people other than our own CE, Teresa Anderson, because we are the only service of our size in Australia, in the Southern Hemisphere actually. And this is a real shame. So our catchment area is 700,000. If we just look at schizophrenia, that means the point prevalence means that we've got 4,200 people. And don't forget, 90% of people with schizophrenia who've been treated for more than 2 years have at least 2 metabolic risk factors. So, I mean, we're probably a very large number of thousands of people we need to see. But when you consider that we see bipolar schizophrenia and severe depression, And it's very hard to differentiate the cardiometabolic risks between those three, because then there's a huge jump to anxiety and the other general high prevalence conditions because they're closer to the general population rates. That would mean we had to see 24,000 patients just in central Sydney. So we're not even including the other partner area in this endeavour. So that means, given that we generate 2,120 columns of data per clinic, and we see 370 people a year, but with all of that data, just to see everyone with schizophrenia in our area from start to finish before we start seeing them again, that would take us 11 1/3 years. But if we had to see everyone at risk with a allied severe mental health condition, bipolar, psychotic or severe depression and schizophrenia combined, it would take us 64 years to see everyone. Clearly we triage, but there are so many people who are not getting the breadth of care or any care that they need to. I'll take you back to the first slide. Why are people losing 30 years of life? And that really is because we don't have enough people to share in the management of that which is actually killing people with mental illness, not suicide, but cardiovascular, preventable cardiovascular and metabolic disease. And this, of course, is where the partnership with general practice must be the solution to this. Yes, we have a whole bunch of people, and at least 3 of our staff have PhDs in medical areas that relate to severe mental illness. We're pretty overqualified, unfortunately, but we need the help in partnership with those that are out there doing this every single day. And so this endeavour that you're all engaged in tonight is an incredibly important one, because why are we all living longer, but those with mental illness in the modern age are dying younger and younger? So I hope I've set the scene for you. You can get some further information on what we do from our website, which is there at the bottom of the screen. And thank you very much for your attention.
Hi, my name's Kizzy, and I'm the lived experience representative. Next, I thought I'd first just start with a quick analogy of what mental health looks like to me. In my opinion, it's like being a house on one of those house flipping renovation shows where, you know, they think they're buying a fairly decent house to do a quick flip or quick renovation on. Next. But when they look underneath the house, the foundations, they realize that it's a miracle the house is even still standing. And that's what mental health is for me. Next. Just a quick history of my lived experience. So my diagnoses include complex PTSD, agoraphobia, and major depressive disorder with psychotic features, also known as psychotic depression, all of which fluctuate in severity. I am, however, considered quite high functioning, and I'm very fortunate to be so, but I'm also very well supported, and I've done and continue to do very intensive recovery work. Next. So I thought I'd just start by going over a few negative experiences of mental health, or discussing mental health with GPs, before I move on to positive experiences. The first being an appointment that I had with a GP at a mental health organisation. The appointment was very rushed. I was frequently interrupted when trying to answer his questions, and I didn't feel as though he was making any attempt to get to know my actual situation beyond my physical health. And I was kind of just told to do things without any discussion. So I really did feel like I was being pushed into things before he understood what was actually going on for me. And it felt as though I was being spoken to like I was stupid. So it was quite unpleasant and demoralizing. And naturally, as a result, I didn't return, I didn't take the medication he prescribed, and I chose to not talk about medication with any other health professionals for quite some time after that. Next. Naturally, I've also experienced somatic symptoms and still do. And I've had some negative experiences around that as well. So this was all before I found my current amazing GP. Not that the others weren't. I used to go to GPs to discuss physical symptoms that I found very distressing. For example, like bleeding when I shouldn't be, really high levels of pain, and difficulty walking straight, difficulty like holding things. And when I brought some of these symptoms to GPs, some of them would say, oh, people just experience this and there's no cause. And it was kind of just dismissed and left me quite confused. For other symptoms, though, the GPs would take them quite seriously and test them, which was very reassuring and validating. But when the symptoms would come back, or the tests would come back negative, it was then dismissed. But there was this one really distressing symptom that was ongoing. And because the test came back negative, I was basically told to avoid mentioning these sorts of symptoms again, because I'd wasted people's time and energy, and nothing else was really discussed with me. So I ended up kind of carrying this around with me for a long time, not feeling like I could talk to anyone about it, but also really not knowing what to do about it. So the only two things I'll quickly say about that would be, I recommend, from my perspective at least, testing all symptoms. It's very reassuring and it's very validating. And of course, it might not actually be mental health related, even though it might seem so. And even when the tests come back negative, to still be treating them as real and distressing, because to the patient, they are real and they are extremely distressing, and they don't go away just because the tests are negative. Next. So onto my positive experiences, of which I have had many. I've worked with 2 GPs who have had a significant positive impact on my health and my recovery. They both focused on relationship building with me to begin with. So they really took the time to get to know me and my overall situation, and not just my physical health. They never pushed me to take anything or do anything that I wasn't comfortable with, and they waited for me to be ready. And they would always ask for my opinion when they were making recommendations. And when I was still getting to know them as well, when I first started seeing them, they also supported me through making follow-up appointments, really breaking it down for me, like, what about, 2 weeks time, and on this day at this time, and now just, if you go downstairs, there'll be a receptionist and you can talk to them about this, and making it very achievable for me. And of course, they took my somatic symptoms seriously as well. So we spoke about very achievable health goals, not just kind of telling me to exercise more, get 8 hours sleep before 10, because those things, when you're distressed and unwell, are not easy at all. Instead, they would say things like, go for a short walk with your dog if you can, or get a little bit of morning sun on your face. And they would also help me. They also helped me problem solve recovery-related decisions that really made a big impact on my recovery. But that's not to say that a GP should be like a social worker, because I know we have social workers for that. It's more that from my perspective, mental health can't be separated from anything else. It's kind of infused into everything. It's part of every aspect of life. And so it needs to be part of the discussion. Next. So from my perspective, I do genuinely believe that you'll achieve much more with your patient if you first ensure that they feel safe, believed, and cared for. Because if your patient feels that way, they're going to be much more likely to listen to you, take on your recommendations, return to see you again, and be honest with you. And this is an important one, because I withhold important information that a GP should probably know until I feel safe enough to share it. So therefore, my key recommendations are to first establish a trusting doctor-patient relationship, and to use a gentle, delicate, and patient communication style. And I say that that's very important because when I'm distressed or I'm unwell, I feel incredibly porous, like even the slightest breeze could just blow straight through me. And medical questions and procedures can be quite confronting and feel quite invasive and intrusive. So little things can feel catastrophic when you're vulnerable. and your sense of worth is generally quite low, and you've probably frequently been invalidated or dismissed. And so having that gentle approach can really make a big difference. I also wanted to briefly mention that, I know that sometimes when people are unwell, they might be prone to sudden outbursts of emotions or getting suddenly very, very angry. And I want to say that in my experience, it's often actually not anger and aggression as it might appear, but actually due to intense feelings of fear or shame, or because you've accidentally touched on a very deep hurt, because in my experience, many people with severe mental illnesses are also highly traumatized. And as Dr. Gabor Mate says, traumas are like open wounds, and even the slightest touch is extremely painful. Also, the patient may not have even realized that the reason that they've had this sudden intense emotional reaction is actually because of traumas and not something else. So things like your tone of voice, your body language, your wording, your rate of speech, even the volume of your speech can make a really big difference. And so, thinking about how to make yourself and the space around you feel a little less threatening makes a big difference. And unfortunately, even if you have the best of intentions, if your communication doesn't reflect your intention, they won't be received. Next. So just to finish off with my little bit, I just wanted to share a little bit about where I am now, but to first say that GPs have honestly made a significant positive impact on my health, my life, and my recovery. So I do believe that GPs are very important when it comes to mental health. I now work as a sole trader speech pathologist for a social enterprise in a small preschool. I feel incredibly valued. I love my work. I also love being a consumer representative. I'm married. We adopted a greyhound. Naturally, my recovery is still ongoing, and it will probably be ongoing for the rest of my life. But it's going in a very positive direction, and I feel happy, which is something I have never experienced before, and GPs have played a big role in that. So thank you, GPs. Next, I'm done.
Thank you very much, Kizzy. That was, and thanks very much for sharing your personal story. I think we're all quite moved by that, and particularly the importance of building the relationship and trust with our patients, particularly those who are experiencing severe mental illness. So we're running a little bit behind time, but we're about to break into some small groups to discuss a case. If I could have the next slide. So this is the case study. This has been sent out to you, I think, beforehand. And it's John, who's a 26-year-old man who was diagnosed with schizophrenia after an episode that involved delusions and paranoia. Reporting his behaviour eventually resulted in his detention by police, and then he was hospitalised for 2 weeks. His family and John have been patients of the practice for many years, and he lives with his family. He's been well up until about the past 5 years, when he became progressively withdrawn, lost his girlfriend and his job, and this was attributed to poor sleep, bouts of heavy drinking, and marijuana use. John's overweight, but has no other physical problems. He's been discharged on an antipsychotic, olanzapine, 5 milligrams daily, and he was allocated a mental health coordinator on discharge with follow-up by the community mental health team. And the mental health coordinator contacts John's GP to discuss some shared care arrangements. So if we can have the next slide. So we'd like you to consider 3 questions that are prompted by that case study. Firstly, what might be some of the priorities for the GPs to manage in this with this particular patient? What are some of the strategies that you have found works well in supporting similar patients in similar situations? And how should the mental health team and the GP work together to care for this patient? So we'll be dividing you in the next few seconds up into some groups. I think there's 22 participants in all. So we'll be dividing you up into about 3 groups. And what we'd like to do is for you to consider these questions. We'll spend about 15 to 18 minutes in the groups, and then we'll come back together and discuss it together. In each of the groups, you'll have a facilitator, which will have some slides. He'll have some slides to show you, just to remind you about the case and the questions. One of the things that we were just discussing when we came back was the issue of how to deal with someone who may be having some thoughts about suicide, and how we should be reacting to that in a calm way and a supportive way, so that we encourage them to continue to talk and to share their concerns. In terms of strategies, there was also some discussion about what really making clear to begin with what relationship the patient wanted, that they and what kind of change they were prepared to entertain, even if there was some fear or embarrassment or concern expressed about things like this, and particularly with this case, the GP seeing the other family members. So establishing that relationship and what sort of care needed to be provided was obviously a key thing early on. And lastly, the third question about collaboration with the mental health team, one of the key things that the GPs raised was being able to access the mental health team when they were needed was critical. That often their experience was that the mental health coordinators, for example, were wonderful to work with, but sometimes they were hard to reach, and when things were when there was a need for intervention quickly. So that was our group. Marsha, do you want to give some feedback from your group, or have you got another person in your group?
I'm happy to give some feedback, and if Jane, you want to also chip in if I've missed anything. Yes. We had a really productive conversation, and I really thank the group for being very open and sharing of their experiences and their knowledge. The first question really elicited to me how much knowledge that GPs have in primary healthcare, and the structure of thorough baseline assessment, planning, investigation, and some of the categories of the things that they would need to track and follow up and intervene was very clear. And so also, as well as the physical side, the holistic care of needing that really the rapport being crucial, and particularly in the first couple of visits, connecting with the person, ensuring that the rapport is built, the trust is built, and the experience of that being crucial was really emphasised. So thank you for that. The other thing was, listing priorities and shared goal setting with the consumers was important, and understanding what they were experiencing as far as side effects, say from medication, what triggers were causing them issues, etc. and talking about this particular case around lifestyle factors being important. One of the things that was raised similar was around collaboration of the team and the importance of that close connection and collaboration with other care team members, and the connection and partnership with the mental health specialist team particularly, that there was a real necessity to know that if things deteriorated, that could be really quickly escalated, and that would be an easy and a very streamlined system in place and process. And some of the points raised were that some of the GPs would really benefit perhaps from a more education skill build, or understanding what other specialities could assist and support, such as in the area of drug and alcohol support for the consumers. And also a question around the role of the PHN and the support for GPs in the shared care space.
Jane, anything to add?
Just one other thing was that it can be difficult as well. We need to recognise that GPs may not be familiar as well with working, managing people with severe mental illness, and particularly when there's a lot of other things involved in it, and with complex cases and involving, for example, involved with justice and police, or even looking at drug use and schizophrenia. So these are things that GPs will need support with.
So thanks. It sounds like you covered a great deal in that group. So thanks. So the third group, I think, was Andy and Patrick. Is that right? One of you was chairing. Andy?
Yeah, happy to provide a few updates. So, similar to the other groups, priorities for the GP were just to start off with getting a bit more info from the mental health team, looking at a physical assessment, and particularly around the person's weight and smoking and drug and alcohol use. Sort of our initial goals seem to be trying to stabilize and normalizing a sleep pattern, but also focusing on, and understanding what his goals are, and what his supports look like, and what his capacity looks like, and so on. In terms of strategies that you have found that works well in similar patients, well, there was an acknowledgement that sometimes when a person presents with a new sort of emerging mental illness like this, it can feel a little overwhelming, and you feel like, well, we can't possibly do everything in a 15-minute session. So just explaining to the individual, this is something where we'll need to have maybe weekly appointments or fortnightly appointments for a while, and we'll build a bit of a relationship and understand our goals. We don't have to rush in and do everything at once, and having that sort of more ongoing rapport. One of our participants has been seeing a gentleman for I think 10 to 15 years, and receives 5 to 10 phone calls a week from him, and just reassures his paranoia for a few minutes, and has that kind of ongoing rapport with him, that he's able to de-escalate a kind of paranoid kind of individual, which is great to hear. Some interesting points in how the mental health team and the GP could work together. I think the number one feedback was just better communication, better information sharing, but also some points like, understanding who does what. So, if a person's linked with a mental health team, can they refer to podiatry, or are there other services that they can get that the GP doesn't need to focus on? And just, having that communication so that we know who's doing what. Little things as well, like, people that are getting 4-weekly clozapine bloods, can we add in a metabolic blood test, from time to time, and communicate that to the GP so that they can work with that. So really just about improving those communication channels.
Okay, thanks, Andy. So we might keep moving, because again, I'm conscious of time. We're a little bit over time. So we might move on to the next presentation, which is you, Andy, presenting briefly on the Sydney Local Health District Shared Care Program.
Yeah, sure. So I can summarize this reasonably quickly. So we set up a system of mental health shared care between mental health service and GPs in around 2018. It was piloted in 2017, and then rolled out across the whole district in 2018. So we introduced, originally we called it a checklist, and we're just updating it and now calling it a care plan, but essentially it's a sort of a list of tasks that we're going to be assigning between the GP and the mental health care coordinator. There's an agreement around improving exchange of information. It's kind of similar to the sort of diabetes shared cycle of care. So it's based on a kind of annual cycle of care, where there's a sort of annual GP physical health check review, and it's supported. We've recruited clinical nurse consultants or shared care clinicians in each of our sectors who really drive the model within the community mental health teams. You can see this little graphic in the top right. The premise is that, you know, in the first month of a new allocation of a care coordination, that we will introduce, you know, book a shared appointment with the GP and introduce ourselves and explain what shared care is. 6 monthly, the metabolic screening is done by the mental health service. And then on an annual basis, sort of we'll order the fasting bloods and book another follow-up appointment with the GP so that when we arrive for that annual check, the bloods are there ready to review. And then we can follow on our checklist. So if we go to the next slide, I can show you our updated checklist looks like this. And if you could click on, we've got a set of tasks that are assigned to the GP at the top here, which, you know, like I say, I'm not going to go through them all, but it's really reviewing those annual bloods, performing an annual physical health check, advising on lifestyle behaviours. We've got the CC chip clinic that Tim spoke about earlier, so making those, reviewing any sort of recommendations if the person's been through CC chip, and obviously preventive screening, vaccinations, a couple of other things. And then we've got tasks assigned to our mental health team in the bottom half of the checklist. So we'll do those referrals, we'll order the bloods so that they're all done in advance, and we'll do the metabolic screening as well and share that information with the GP. So that's the idea of the program. And if you could just click onto the next slide quickly, I'll just show you some of our numbers. So since we finished our pilot in January 18, the numbers of the purple is the number of people who are in shared care arrangements. So you can sort of see where it's dipped off through our COVID lockdowns, understandably. But other than that, we've managed to get around a third of our community mental health cohort of 2,000 enrolled in shared care. The numbers have leveled off, but there are still 20 or so new arrangements being made every month, but they're now being sort of matched by discharges every month. We've got over 300 different GPs involved in the program, which is the orange line, and the green line is those annual physical health checks. So around 2/3 of people in shared care are getting those annual physical health checks, and we're going to be really hoping to drive that model forwards in the coming year now that we're hopefully saying goodbye to lockdowns. That's it from Sydney Shared Care.
So thanks, Andy. So now, Patrick, would you like to talk about the shared care in Southeast Sydney?
Sure, thank you. So I'm a complex care physician on the Randwick Hospital's campus. I trained as a GP, but ran Prince of Wales and other hospitals for many years. So in some senses, I'm a fly on the wall, both in terms of general practice and mental health. I work with both of them, but not of either of them. And my perception is that the mental health service, not surprisingly, is concerned with these people as people with mental illness. And it often sees them when their illness is bad, and often in situations that involve some degree of coercion. So it's not surprising that the person with the mental illness is ambivalent about the health service. And I wanted to do a wonderful graphic that turned from one thing to another, but I'm not clever enough. So on the screen, what you can see is my view about a person with mental illnesses' view of life. Although this could be almost anybody's view of life, which is life is the big picture. Life is mostly what happens to you. I've made the healthcare bit possibly bigger than it needs to be, but there it is. I had to do that for font sizes. The mental health care part is only a small part of that, and clozapine prescribing is a tiny part of that. Whereas if you did it from the mental health service point of view, the colours would be reversed. The biggest bubble would be the clozapine, then there'd be the mental health care, then there'd be healthcare, and then there'd be life. There's that tiny little dot in the middle. And that's the opportunity in general practice. The mental health service there's a variant of the saying, if the only tool you have is a hammer, then everything looks like a nail. The mental health service is just interested in mental illness. I see significant physical illnesses get completely overlooked because the mental health service just doesn't have that focus. I mean, I have to say, I see the cardiology people overlooking other body systems as well. So it's not just about mental health, but that's what we're talking about tonight. So the benefit of working together is, in fact, is hopefully that we can make this both more about people in their everyday life and also address some of those really wicked problems about the physical health problems that these people have that Andy at the outset described. Thank you.
Thanks, Patrick. So now we're going to shift gear a little bit and talk about some of the support and referral services, and I'll hand over to Abhishek.
Thanks, Mark. So look, again, in the interest of time, I will try to keep most of this quite brief. A few of these have already been mentioned as well, so I'll really only touch on them. So to start off with CC Chip, we have heard a little bit about CC Chip already. Essentially, it's a one-stop shop health checkup clinic, so it involves everything integrated within the service from screening, detection, management, and follow-up of metabolic disorders for people living with severe mental illness. The referral into the service and information about where sites are located, all of those can be found in the link there. So I will leave that up to each individual to kind of look through and find what's appropriate. There's also PDF versions of the referral forms and a HealthLink Smart form as well. That's on the website there. So that's something that we can look through. Next slide, please. The next program is the Keeping the Body in Mind Primary Care, or KBIMP program. This program is a free service funded by assessment for people aged 18 to 65 living with severe mental illness. Primarily, it's based in the UNSW Lifestyle Clinic in Randwick and has also been operating with telehealth through the lockdown period. And it provides up to 8 sessions with an accredited exercise physiologist and 8 sessions with a dietitian. And you'll get other resources around exercise and diet along the way as well. And this slightly different to the previous service is that it's available for people not currently managed by public mental health services. Again, for further information, the links will be provided to you, so you can find it through that. But also, it's under the physical activity request section in Health Pathways as well for those familiar looking through the health pathways. And it's an online GP referral link. And there's also a QR code if you click through there that you can find. So if you're more familiar with using a QR code, there's also an option to look through there. Next, please. So that's the QR code right there. Next. Yeah. And next section here, I'll just go over some useful resources. So this is a little bit taking a step back as well, not just on specific services, but more around service navigation and how to make that easier. The first resource that you might be familiar with already is the assessment website. So the website includes a whole lot of information about all assessment commission services, everything from low intensity to suicide prevention. And it gives a short overview of each program, eligibility criteria, key contacts, and the referral process. There are also regional planning, training, support, resources, and other useful links available through the website. For those that aren't as savvy and want to navigate the website, because it can be a little bit tricky, there's also the Assessment Services Guide, and this provides a full list of assessment services from workforce development, practice support, clinical support, mental health, Aboriginal health, AOD, and the like, really. It also has information on PWI and immunisation CPD. Yeah, it's fairly easy to navigate. It might be a little bit easier than the website, so it's really under the one PDF. And then the next sort of resource there is also the Head Start page, which is a web directory that's locally catered, that has locally catered information. So this website is is made more so with the general community in mind, and it is something that you can give as a resource for consumers coming through your practices. And it's really about how to make that navigation of local programs a little bit easier. So there's search options for different diagnosis types, the types of services that you're looking for, or if you're not really sure and where to really get started. So it's a useful tool there. And another resource there to add is the mental health skills training. So this is allowing GPs to access additional mental health Medicare rebated associated MBS item numbers, so the 2715, 2717. And by completing this module, you'll be able to build with those item numbers, and the links provided there are through the RACGP and Big GP and their training modules that you can go through and use to upskill. Next slide. And just a couple of services again, just to round off again, taking a little bit of a step back. So the first one there is Head to Health. So this is a reasonably newer sort of service that's been available, and it's made with the New South Wales sort of extended lockdown period due to COVID in mind. And this is a 1-800 number that allows anyone to really speak with a trained mental health clinician, and they can direct you to an appropriate service. So again, it's something that you can hand out to consumers that come through your door if you're unsure yourself. It's a number that you can call. It's particularly useful for our region, assessment region, because we have a couple of pop-up sites within our region, being at Hesfam and Lakemba. And so you can also direct any consumers to those pop-up sites, and same sort of service there. So you can drop in to those sites, and a mental health clinician is able to direct you to the right service in the area. The service navigation for psychosocial supports, this is a bit more targeted toward the psychosocial supports. So this service works particularly closely with NDIS local area coordinators, and they help to disseminate information. So again, more of an information service. It's for consumers and GPs, so anyone can really call through the line. And the last one there is the psychiatry support line. So this is around any sort of psychiatry needs that you might have, or questions that you might have. So it provides, you can call in and get the service around diagnosis, investigation, medication or safety planning with a consultant psychiatrist. You will need to register before you use the service, but after that, you can use it as many times as possible. And there's some more information on there. And again, all of this, you don't have to keep a record of this. We'll send this to you so you can have access to all of these resources.
Okay.
I think that's it for me.
Thanks, Abhishek. So I think, Andy, you're going to chair the Q&A session.
Yes, so I guess we're just going to hand over to the participants. We've got about 7 or 8 minutes to fire any questions related to today's themes to any of our panel members. Does anybody have a burning question they'd like to ask?
I think people can also write it in the chat if you feel you don't want to use your microphone.
Perhaps I'll start things off and ask you, Mark, or as you're from your experience with it as a GP. You know, we were hearing today from Kizzy about the importance of taking things slowly and building rapport and building a relationship with her, and that how effective that was. I just wonder, with the way that our Medicare billing system is set up, and for a GP, you know, time is money. Does it take an altruistic GP to actually be able to provide really good, comprehensive mental health support in a primary care setting?
The short answer is probably yes, but I think that it certainly, particularly initially, can take quite a long time, and that can be, you know, not particularly well remunerated from Medicare. There are obviously options that provide longer care, like, for example, a long consultation or using the care plan as particularly if the GP initiates the care plan, then that's relatively better funded than a standard consultation. But of course, that also involves more time and more work. I think from a GP's perspective, it's often not just the money, but the sort of disruption. This is such as the case study, that's a situation that you wouldn't necessarily plan for. You may not realize when the appointment's being made that, what's a very complex case is going to walk in the door. And so that can be quite disruptive to the practice. You can have other patients waiting and so on. So, and at the same time, you're trying to balance spending enough time with the patient so that you can establish a relationship, but also a concern about safety, about ensuring that things are managed in a way that's not going to get out of hand, and where the patient might go away and self-harm or something like that. So that's always in the back of GP's mind. So all those things can make it difficult. And I think personally, I've found that is often as big a concern with a patient that fortunately is uncommon. It's not the sort of patient that's every second patient. These are, we see obviously conditions like simple anxiety disorder or depression much more frequently, but patients with severe mental illness we don't see very often. And I guess the thing that a lot of GPs find difficult is the disruption to their kind of organisation and pattern of their practice. So how to deal with that is a real challenge, I think. But strategies like arranging a longer consultation, like using a care plan, like communicating with the mental health coordinator to get some additional support while the patient's while management's being initiated. So that would be my approach. I mean, you yourself or Patrick might have other things to add to that.
I mean, I guess some academics have stated that people with severe mental illness actually attend GP more often than members of the general public, but they receive much lower rates of screening for physical health comorbidities. Is that because of the very low levels of health literacy, perhaps, and people not being very good at advocating for their health needs, or the subtle impact of biases like diagnostic overshadowing, or and what can we do about it, I suppose, is the question.
I think it's often because it's often that diagnostic overshadowing is, it's such a difficult thing to manage, and there's so many complexities to it, both in terms of the patient's life and the other members of the team that might be involved and so on. All of that's very difficult, and so that can be a real problem. I notice there's a comment in the chat.
Yeah, Paul has written, just because you're paranoid, it doesn't mean you're not being followed. It reminds me of an old Nirvana lyric, I think. But in other words, it works as well for physical health. You must take all physical complaints seriously. And Kizzy spoke very passionately earlier about her experiences of being told, there's nothing physically wrong with you. So what can you're just going to have to live with it, and how sort of invalidating and demoralizing that can be.
Mm-hmm.
I can understand that's a real challenge for a GP though as well, who feels that what more can they do to help this individual.
Can I chime in with a couple of thoughts on that? One is that we know for the general population, only a quarter of antihypertensives are taken as prescribed. So while that's a problem, I'm anxious that we don't beat up people with mental illness for being non-adherent to their medications as a special case. The second thing I'd say is that Nada in our breakout group made the point, what does the client want? You know, that needs to be driving. If the client wants and can go along with best practice in preventive medicine, fantastic. If the client's not interested, it does create risks for them in terms of their health outcomes, but it's really important to work with them and their wishes. And the last thing I'd say is there are sometimes opportunities for what I think of in myself as commando interventions. Get in, do the intervention and get out again. And the star one for that for me is treating hepatitis C. You know, if you can just concentrate on them, ideally with a case manager for the course of the antivirals, then you can, and they don't, the emerging evidence is you don't have to be perfectly adherent to your hepatitis C medications, or that's obviously not the message you want to give to the patient. Then you can cure this illness, which often has this negative impact on how they're feeling, impacts therefore on their mental health, long-term risks of cancer and cirrhosis. Another one would be triple therapy for H. pylori. I mean, there's not lots and lots, and dental care is another one. Not lots and lots of these things, but there are some things which are worth thinking about because you can do them in a focused way and make a tangible difference to the person's health outcomes and or quality of life.
And immunisation is obviously an important one, and not just COVID.
Absolutely. Thanks, Mark.
The same issue. And you know, that's obviously it's much more challenging when you're talking about things like smoking cessation, but yeah, there's a lot that can be done, and it's making a start with what the patient sets as their own priority. Okay.
Sorry, Mark, can I just mention one thing that was raised in our group, which I'm going to go back to because it's about building a rapport and trust and patterning. And this happens when consumers come to mental health service and say they don't know you and they're coming for the first time or the second time. It does need more work. It does need settling down. But once that person gets into a routine and knows their appointment system and perhaps scheduling those appointments at the beginning of the day so you're not behind, and really getting into that routine to prevent that disruption could be something to think about. And that could be about targeting an appointment system for them to regularly come rather than turning up in a disrupted way. And our consumers are very reliable in general once they get into the pattern of regular blood tests, etc.
And Charlotte's made a comment in the chat, which is very apt. Remember, we're in for the long haul as a GP, not just an acute episode of care. So that's, I think, a very important comment. I think we probably should move on. I just want to say two things, really, to ask you to complete your evaluation form. In that, we're asking you about what further education you would like to have. And we'll be sending out the presentations and so on, but please complete that evaluation. And because really what's next is that we'd like to, this is really only scratching the surface of obviously the sort of issues that have been raised here. There's a lot more to cover. We'd like to provide some more education that's going to suit your needs. So that's going to be very important. As has been said, there's a couple of shared care programs that run in both Sydney Local Health District and Southeast Sydney, and we'll send you some information about those if you're interested in being involved. That would be great. And I think that's about it. So thank you, and thanks everyone for all the presenters, including Andrew and Tim Lambert and Kizzy and all of you for participating in the small groups and in the updates that we'd had on the shared care program from Andy and Patrick, and also Abhishek's updates on all of the programs that are being support services are available through the PHN. So thank you.